Chapter 15, Injuries to Muscles and Bones. There's been lots and lots and lots of different types of injuries one could have to muscles and bones. Things that we're going to see in this chapter include fractures and dislocations, sprains, strains, head injuries, spinal cord injury, and chest injuries. We need to understand the basic anatomy and the function of the musculoskeletal system. In order to help treat these injuries, you must be able to recognize the signs and symptoms of various musculoskeletal injuries and provide proper care at the scene to prevent additional injury and disability. As with all medical emergencies or illnesses or injuries, we always have to first do our proper scene size up. Primary survey: is the patient alive, dead? Are there any life-threatening conditions such as arterial bleeding, things like that? A history taking, a head-to-toe inspection, a secondary assessment, and a reassessment of the patient of the vital signs about 15 minutes later if they're stable, around about 5 minutes later if they're not in a stable condition. All right, we complete all the 5 parts of the patient assessment sequence. All right, follow the standard precautions to protect yourself and the patient from infectious diseases. Perform a complete primary assessment, immediately followed by a secondary assessment. Perform a thorough sample, medical history, and continue to reassess the patient on an ongoing situation. You must remember that the skeletal system consists of 206 bones, and in that 206 bones in the body, it makes up the framework, fully functional skeletal system that supports the body, protects the vital structures, assists the body in movement, and used for the manufacture of red blood cells, white blood cells, storage of bone marrow, fat, things like that. They're divided into 7 areas of the body: head, skull and face, the spinal column, shoulder girdle, upper extremities, rib cage or thorax, pelvis, and lower extremities. Right, there's a picture of the thing, skeleton as it is. All right, as the anatomical man would be, on his back, palms facing up, thumbs facing outwards, and all the bones are there for you to see. The bones in the head of the head include the skull and the lower jawbone. Okay, and the movable jawbone is attached to the skull. The spine consists of a series of separate bones called vertebrae. They work together in a series. There's 5 sections of these bones. The cervical spine, C1 to C7, thoracic spine or upper back, T1 to T12, lumbar spine, L1 to L5, lower back, sacrum are fused, 1 to 5, the coccyx or tailbone is fused, and they're 1 to 4 normally. There's a good picture of it in the alignment. You need to know the order in which they come. Remember, thoracic bones, there's always 12 because there's always 12 ribs. There's 33 in total. Each shoulder girdle supports an arm consisting of a collarbone or clavicle, shoulder blade or scapula. The upper extremities consist of 3 major bones plus the wrist and the hand. Okay, the top bone is called the humerus, the arm. The forearm is the radius and ulna. The wrist are called carpals, hand are called metacarpals, and the fingers are called phalanges. With the skeletal system, there's 12 sets of ribs, as I said just now. These 12 sets of ribs protect the heart, liver, and spleen. All of the ribs attached to the spine, and the sternum is located between the ribs in the front of the chest. The pelvis links the body extremities, the upper body and the lower extremities. Pelvis protects the abdominal organs and reproductive organs. Lower extremities consist of the thigh and leg. The thigh bone or femur is the longest, strongest bone in the body. The leg, the lower extremity consists of tibia and fibula plus an ankle, which is your tarsus bones, metatarsals in the foot, and phalanges in the toe. The muscular system provides support and movement. Okay, muscles are attached to the bones by tendons and cause movement by literally contracting and relaxing. Movement occurs at the joints where two bones come together. Okay, bones are held together by ligaments, and on the end of the bones is usually quite a thick piece of cartilage so that the bones don't rub against each other, and there is synovial fluid between these joints. Voluntary skeletal muscles are attached to the bones, okay, and they can be contracted and relaxed at will. The brain usually tells these muscles or which bones to move and things like that, your arm, your leg, whatever. Involuntary or smooth muscles are found inside the digestive tract and in other internal organs. Also in arteries. Cardiac muscle is only found in the heart. There we go. There's three types of the muscles: cardiac muscles, skeletal muscles, and smooth muscles. All right. When we look at the mechanism of injury or MORs, there's always some sort of external force that's been produced on the body, whether it's direct force, indirect force, or twisting. Must remember, bones and things like that don't break or tear without some sort of force on the body. We need to be able to use the information provided by the dispatcher and gathered from the scene to identify the possible mechanism of injuries or MORs. There are many different ways to describe the patient's injuries. Use your senses of touch and sight. Listen to the information the patient gives you, and most important part of your job is to provide the best assessment and treatment for that patient. Different types of injuries. Fractures. A fracture is a broken bone or breaking the continuity of the bone. Most often occurs as a result of significant force. Bone is actually more dense than concrete, so there has to be some sort of violent twisting or force placed on that bone. A closed fracture, the bone is broken, but there's no break in the skin. And in an open fracture, the bone is broken and the overlying skin is lacerated. Both result in bleeding at the fracture site and can be quite a nasty thing to experience. Must remember that with open fracture, we don't ever try and replace bones or anything like that. Dislocations. Dislocation is when a joint is twisted or turned further than its normal capabilities. The ligaments that support the joint tear, and one end of the bone becomes separated from its position in the joint. Okay, any attempt to move a dislocated joint can be exceptionally painful. Dislocation can damage nearby nerves and blood vessels, and we never want to try and put dislocations back in case one of those blood vessels or nerve becomes pinched in the process, in which case that extremity would probably be useless forever unless major surgery and things is done to try and restore those things. Sprains and strains. Okay. A sprain is a joint injury caused by excessive stretching of ligaments. A strain is caused by stretching or tearing of the muscle, something like a hamstring. Signs and symptoms of extremity injuries is always going to be pain at the site. One would never be going amiss if you used the acronym DOTS when looking for these kind of injuries. Pains, open wounds, swelling, discoloration, maybe bruising, the patient's inability or unwillingness to move the extremity because it's sore, deformity or angulation, when you look at the patient and you see, but the foot shouldn't be twisted that way around on the body, you can see straight away that there's deformity. Tenderness at the site of injury. Anybody who tells you they've broken a bone or twisted an ankle or something, will tell you it's exceptionally painful. For most people have been through that in their lives. Standard precautions for musculoskeletal injuries. Assume that trauma patients have open wounds and these pose a threat of infection. We never touch a patient. The next point goes without saying. We never touch a patient without having gloves on. Okay, when you respond to motor vehicle crash, make sure that you have either 2 pairs of gloves or a heavier set of rescue gloves, something like leather gloves or something like that, which will protect you from glass and other sharp materials. The patient is actively bleeding, it may splatter. You should have protection for your face shields, especially eyes, goggles, things like that. Face mask if you really want to prevent any blood squirts or anything like that from getting on you. When we examine musculoskeletal injuries, we always follow the steps of the assessment process, okay, before focusing on injured limb. Obviously, if ABCs are failing, we need to provide CPR, or at least maintain airways and things like that. Limb injuries are not life-threatening unless there is an arterial bleed or excessive bleeding. Examination of the limb. When we inspect the limb, we always compare it to the opposite side of the uninjured limb. When you examine a limb, when you find any of the following, the dots, deformities, open wounds, swelling and bruising, tenderness, we always palpate or feel with our fingers, both hands, squeezing from the top of the limb down to the entire limb in a fully systematic manner. We never stop to treat something. We continue and then always go back and treat at the end of our inspection. Examination of the injured limb. You could conduct a hands-on examination while you ask your patient where it hurts most. The location of the greatest pain is probably the injury site. If a patient shows no sign of injury, ask them to move the limb carefully. Ask them if they can, if it's a foot, can you wiggle your toes? Can you feel it if you touch lightly on the toes? Make sure there is always circulation. There we go, circulation, sensation, and movement. Sometimes there may be an injury where the nerve is damaged or the blood vessel is compromised in some way. There could be an occlusion or something like that, blocking the blood from getting to the foot. Check, is it cold? Is there feeling? And is there movement? Okay. All limb injuries are treated in the same way in the field. Cover open wounds with dry sterile dressings. In other words, stop the bleeding. Apply a cold pack if painful and swollen or deformed extremities. Splint the injured limb and always splint it in the position you find it. Don't try and straighten it. Don't try and push things back in. General principles of splinting, okay, prevents the broken bones from moving, prevents tissue damage and a dislocated joint, helps control bleeding, decreases the risk of additional damage, and prevents closed fracture from becoming open fracture during movement or transportation. Please don't encourage your patient to walk if you suspect he has a broken leg. General principles of splinting. We need to inspect for open wounds, especially if you see bleeding or things like that. We need to remove the clothing from the injured limb and check to see if we need to control bleeding or not. The bleeding has stopped. Cover the injury, cover the open wound to prevent infection and things like that from getting in. Always check for sensation, capillary refill and distal movement below the point of injury, and record your findings. Don't move the patient before splinting unless he's in immediate danger. Immobilize the joint above and below the injury site. Very, very important. Not ever on the injury site, always above and below, about 5 centimeters above, 5 centimeters below. Remember, we can't immobilize on a joint. We'd have to go above and below the joint to splint adequately. Okay. Pad all rigid splints. Make sure that there's not going to be any damage or cut off, disruption in circulation. We never tie knots or anything on top of a limb. We always tie against a hard surface if you're using bandages or triangular bandages to secure a splint in place. Okay, the splint will prevent the limb from moving unnecessarily. And always remember, if you're not sure, splint anyway. I always tell the people, whatever splinting material is available, use it. You could use anything from a rolled up newspaper to a pillow to a plastic bubble wrap type thing that you get inside of a printer cartridge. Anything that you can find that's rigid or will provide support is good for things. I always carry personally, I carry a SAM splint rolled up in my first aid bag. They are surprisingly rigid, okay, and offer support and are very easy to use. They adapt nicely to the shape of the patient's arm. Soft splints, like vacuum splints and inflatable ones, and clear plastic. You could even use a pool noodle as a splint. As long as it supports the structure, you can wrap it around like a pillow and stop the thing from moving. There's a vacuum splint. It looks like a giant blood pressure cuff. Just make sure that when you use a vacuum splint or something like that, or an air splint, that you don't overinflate and block off circulation. Traction splints. Something we're not going to use out in the field without exceptionally well-trained people to help you. We're not going to ever use a traction splint where the patient has not been given some sort of painkillers. It does have its place in the emergency role, but not really for a person without qualifications to use these things. You would always have to have a second rescuer to assist you in any case. So best this kind of thing is not used unless it's a serious emergency. And I can't actually think of any emergency that you would want to use this type of thing. It would be incredibly painful for the patient for you to use a traction splint on them while they have not been given any pain medications. Remember, when any type of shoulder injury, arm injury, or hand injury, we want to provide a sling for the patient. Okay, sometimes with rib injuries, we want to pad the rib and bandage it up as well. So we want to use a pillow underneath the rib cage or underneath the arm and strap the arm fast to the pillow. With elbow injuries, don't move the elbow, keep it in the position you find it in, and always provide some sort of a sling if the arm is bent. They're using a pillow for a splint, wrapping it tightly. Always remember that once you've wrapped it and packed it and got it in a sling, check for distal circulation, check for sensation, and make sure that there's still a certain amount of movement and things like that in the fingers. You never want to wrap it so tight that the patient can't feel his fingers moving at the end of that type of thing. All right, like I said earlier, we can even use a cardboard box for a splint, SAM splint, or rolled up newspapers or magazines, whichever you have available to you. Always remember, with hand, wrist, and finger injuries, okay, dressings can be bulky and use a short splint. If you have amputated parts from injuries from hands and things like that, always make sure that once you stop the bleeding, you recover the amputated part, clean it, wrap it in a sterile dressing, place in a plastic bag, and send it to the patient with some sort of knowledge of the time of amputation. Always remember, with finger injuries, especially individual dressings around each finger, if the wound is open, in other words, there's no blood or anything like that, you always place a wet dressing, keep it as sterile as possible. We would use things like burn shield with burn wounds on fingers, and always keep it in a nice, comfortable position, the hand that is, and place soft roller bandages underneath the palm if necessary. Apply splint to secure it with a soft roller bandage. Specific injuries, pelvic fractures. Pelvic fractures are always a very dangerous thing because of the blood vessels and the arteries that run over the pelvis. Okay, whenever we're treating treating pelvic injuries, we must also be prepared to treat the patient for shock. Okay, there's a good chance of blood loss. Inside the pelvic cavity, you could lose up to 5 liters of blood. Don't try and raise the legs. If there's any pain or any movement in the pelvic girdle, we want to keep the patient as still as possible. We're going to feel with both hands for tenderness, okay, and deformities in the patient's pelvis before we may have to use a pelvic splint or make. One has to remember that one of the most painful fractures you can have is a pelvic fracture. The patient will not be able to move their legs. They won't want to lift them, they won't want to move them. You're not actually going to move the patient without causing immense pain to the patient. So always be aware of these things when checking for pelvic fractures. It's very dangerous. Hip fractures, especially common in elderly people. Okay, they're both high energy trauma. Fractures occur in elderly people because of weak bones, become more fragile with age. Remember, it's not actually the hip that breaks in an old person, it's probably the neck or femur that will be breaking. Okay, so if you find that the leg is in an unusual position, or one leg is a lot shorter than the other one, shortened, we're always going to suspect something like a hip fracture, especially if there's pain in the area. You're not going to want to move that patient. Remember, there are broken bones that are sticking out that could cut arteries, nerves, and things like that. We want to make sure that we have a lot of people around to help us move the patient, give the patient some sort of medication, pain before moving them. Try and keep the patient, my suggestion to you would be keep the patient as still as possible and await for help to arrive. There is no real injury that's life-threatening in a hip thing unless it starts to cut off arteries and things like that. Thigh injury, the femur is a fracture of the femur is very unstable. Okay. Place the patient to come to a position most comfortable for them, treat for shock, call for additional personnel to help. Traction splints would be an effective way to splint in a unilateral fractured femur. Please be careful. As I said to you before, we don't really want to put traction onto anybody that hasn't had any medication, things like that. Certain complications from fractured femurs could be arterial bleeding, where the bone is broken, cut off the artery that runs really close to the bone. If the artery is cut, okay, there could be a good chance of bone marrow leaking out of the fracture, getting into the bloodstream, causing fat embolisms, things like that. Always something to be very concerned about. With large bone fractures, pelvic, femur, hip, things like that, we never want to move the patients on our own. We want to get other help and get them moved in a stable method as possible. All right, so there's just a couple of pictures. Okay. If you can't, we don't encourage people to straighten the legs for splinting. Okay, try and splint it in the position you find it in. Otherwise, wait for help to come. Hire qualified help where they can give you the best advice possible. There's a good example of a knee injury, whether it's dislocated, broken, things like that, torn ligaments. Always try and stabilize in the position that you find it in. Okay. Fractures of the leg can be splintered with air splints, cardboard splints, especially the lower limb. Anything, cable wire splints, K-wire splints, or like padded splints with a metal frame on the inside can be used quite easily. Fractures of the ankle and foot, either you can splint with a pillow or an air splint. The patient's boot is on. Please don't remove the boot unless the foot is swelling, or you need to see for some bleeding. The boot will actually keep the ankle in shape and prevent it from becoming deformed in any way when it's loose and out of the boot. Okay, you need to be able to splint quite effectively on your own, but most splinting requires two people to put it together and to stabilize the limb properly. Okay, we look at head injuries, brain and skull, and injuries to the spinal cord, common and cause death. Okay, can lead to irreversible paralysis and brain damage. Okay, basically the skull consists of two parts, the cranium and the facial bones, mandible and maxilla. There we go, a picture of it, upper jaw, lower jaw. Always look at the mechanism injury. Between the skull and the brains, there's cerebrospinal fluids. There are certain membranes, 3 in fact, that surround the brain. Okay, direct force into the skull and the brain. Things like concussion, contusion of brains, subdural hemorrhage, things like that will all be things to be concerned about when you find a head injury. Okay, closed head injury where there's bleeding and swelling, swelling within the skull will increase pressure on the brain and could lead to brain damage, or in fact, will lead to brain damage and death if it's not seen to. Open head wounds bleed profusely. There's a lot of nerve endings in the face and the skull. So there's a lot of little blood vessels that feed these pieces. So anytime you've come across an open head injury or facial wound, things like that, you will see that it's bleeding profusely. We don't wash or try and clean out these wounds because you're just going to wash away the blood clots and start the whole process all over again. Apply gentle pressure when putting a dressing on the head for injuries, for open wounds. Okay, and try and avoid any disruptive things to that part of the body. Okay, when examining the eyes, the nose, okay, the wounds, make sure that it's just plain blood that is seeping out or not cerebrospinal fluid coming out of the brain tissue or bone may also be visible. So just put a light dressing on those things, not putting pressure on it. Always try and control the bleeding as best as possible. Okay, there can be many different types of actions that cause these injuries. Blunt force trauma, penetrating trauma, things like whiplash, those kind of things would add to these type of injuries. Now, signs and symptoms with head wounds, okay, head and skull injuries, would include things like confusion, especially if they get kicked in the head and they have a concussion or hit on the head quite hardly. Unusual behavior, they do the craziest of things. Unconsciousness is definitely an issue. Pain at the site of the injury would be another thing. Nausea and vomiting, blood coming out of the ears. There's a very easy way to determine whether the blood coming out of the ears is from cerebrospinal fluid or from a burst eardrum. The burst eardrum will be exceptionally painful, throbbing, be complete loss of balance. Okay. If it was a other type of head injury, there would be pain, but there wouldn't be as that throbbing pain. All right. Decreased consciousness, unequal pupils definitely would be a sign of an injury to a brain. Remember that if the right eye is unresponsive to light, if you do a test, probably the left-hand side of the brain start looking for an injury or bruising or deformities on that side of the head. Paralysis, if you suspect a neck injury or brain type of injury or swelling on the brain, maybe pushing on the nervous system and making setting up for paralysis of that areas. Seizures, quite often seen in sporting events, kickboxing, boxing, things like that, where the patient gets hit really hard and they have a seizure. Definitely something to be concerned about. External bleeding, always bumps and bruises, things like that. Keep a good lookout for those things when doing dressings. Patient will complain about pain. Then we have a good example of head injuries, raccoon eyes, a very serious injury, usually denoted by some sort of head or skull fractures. Okay, raccoon eyes, battle signs, bruising behind the ears. All right. Must remember that when we're dealing with head injuries, it's important for us to immobilize the head in a neutral alignment. We'll use the guides as a nose, sternum, central pubic bone, or belly button, to try and get the spine in straight as possible as possible. Yes, maintain an open airway. Remember that if we have suspected spinal injury, we're not going to use a head till chin lift. We're going to try and do something like a jaw thrust maneuver. Patient is unconscious, some sort of airway adjunct, something like that. Always be prepared to open to suction a patient. Remember, when we're doing suctioning, no longer 15 seconds, only what you can see, only while withdrawing the catheter from the patient, and don't, whatever you do, stimulate the gag reflex and get the patient vomiting while they're trying to lie on their back, and you try to keep them immobilized. Support the patient's breathing if they need oxygen, and you're trained to do so by either a high flow rate of oxygen, or if it's not so bad, a medium or to low flow rate, just supplemental oxygen. Keep the oxygen saturation levels up. Always monitor ABCs and be prepared to perform CPR if necessary. Okay, if we determine whether it's blood or CFS leaving from the ears, we never block up any ear injuries or anything like that. We encourage it to, any blood or anything to leak or roll out of the ears, can come out the ears. We don't want to have anything blocking up those ears. Control bleeding as far as possible. Clean sterile dressings. Remember, they are very serious head injuries. Don't apply too much pressure. Arrange for rapid transport, especially if you see signs of some sort of brain damage or swelling on the brain. Facial injuries, okay, motor vehicle accidents, things like that. Windshield, when the face hits the windshield or the steering wheel. Maybe assaults, falls, things like that. One could also encounter facial injuries with dog bites and things. Okay, remember, bleeding is quite intense. All right, make sure that the airway is unobstructed. Okay, especially in an unconscious patient. If a patient is bleeding from the mouth and things like that, make sure that the blood is not running down the back of the throat. If you don't suspect spinal injury, put them in recovery position once you've stopped the bleeding. If they're bleeding and you want to try and stop the bleeding, make sure that you stabilize the spine, okay, and keep an open airway. Okay, always support breathing, monitor circulation, control, cover bleeding. Obviously, we always want to control bleeding, and look at stabilizing other injuries once you've done your secondary survey. Arrange rapid transport to hospital. Trauma boards are things of the past almost. We try to avoid using trauma boards for long exposure to hard surfaces. Sometimes these hard surfaces in a patient whose circulation is compromised would often cause things like pressure sores, and we do not want to do any harm to the patient more than they've already been hurt. With spinal injuries, we always going to expect to see some sort of paralysis. If you have a head injury that you can see there's open wounds or anything on the head, we're going to expect that we're seeing some sort of spinal injury as well. In severe cases of spinal injuries or things, the spinal cord may be severed and the patient will definitely show signs of paralysis. Okay, high spinal cord injuries would cause death due to the paralysis of the diaphragm. 3, 4, and 5 keeps you alive. So any injury above C5 would definitely be a very serious concern. Gunshot wounds to the chest and abdomen may produce spinal cord injuries as well. and cause the patient to be paralyzed. Falls from a great height than your own height, motor vehicle crashing, stabbings, and being thrown from a moving vehicle are other common methods of injuries. Okay, always suspect a spinal injury if your patient has sustained high energy trauma. In other words, fall onto a hard surface, being thrown from a moving vehicle at speed, things like that. Some of the signs and symptoms you may expect to find in a spinal cord injury: lacerations or bruising, other signs of injury around the head, neck, and spine, tenderness at any point in the head, neck, and spine, pain in the neck, spine, or radiating into an extremity weakness or numbness, paralysis or loss of movement, either one leg, both legs, things like that, loss of sensation of movement or tingling, burning sensation any part of the neck, loss of bladder or bowel control, usually a good sign that there's something going on with the spine. Hey? Always place the head and neck into neutral alignment, unless when you're placing the head into neutral alignment, the patient starts to feel paralysis, numbness, tingling, sensation, electric shock sensations in an extremity or part of the body. Stabilize the head and neck to prevent movement. Always, when you find a patient that you suspect a spinal injury, encourage the patient not to move. Sometimes you may have to administer oxygen if you're trained to do so. Keep the airway open, maybe a jaw thrust maneuver. The patient is unconscious but still alive. You may want to consider something like an OP tube, an airway adjunct, to try and help keep it alive. It's also easier to suction if there's something keeping the mouth open. Always assess the pulse, movement, sensations in extremities, and monitor closely. If ABCs fail, begin CPR. After we've stabilized the head and neck, we're always going to check and treat for other serious injuries and arrange rapid transport. When stabilizing a neck injury, we want to try and support it. Although hard collars aren't really used anymore, there's no harm in using a soft collar, or if you think there's a serious problem, using a hard collar until you can get some help to help you stabilize the patient more. Put him onto a trauma board or onto a scoop stretcher with the proper supports and headrest in place. Motorcycle helmets and sporting helmets, unless the patient has a breathing problem and we need to ventilate the patient, give them additional air, oxygen, things like that, we don't want to remove that helmet. Okay, helmets sometimes keep the patient head almost in a splint, I would say. Neck moving the patient's head and neck would also possibly cause injury to the neck. Okay, if you have to remove the patient's helmet, one would always support the head and chin, neck, and while taking the helmet off, we would walk it off, try and open the helmet from the sides, pull it out, and while one rescuer holds the chin and under the neck at the back and the base of the skull, the other rescuer would walk off the helmet in a very gentle, controlled manner. Once the helmet is really off, make sure the head is not going to fall. Remember, the helmet is big and it's going to cause the patient's head to drop if you don't support it properly. Chest injuries or rib fractures. Okay, even a simple rib produces pain. It's the difficulty breathing, sneezing, coughing, anything like that is impossible. Pain is intense. Okay. Rib fractures may also be associated with underlying injuries to organs, lung contusions, punctured lungs, things like that. Determine whether the ribs are bruised or broken. Apply some pressure to another part of the rib and see if it's also painful there. Be alert for signs and symptoms of internal injury, particularly shock. Place a pillow against the injured ribs and splint them. Prevent excessive movement of the patient. Administer oxygen if necessary and if it is available. In the flail chest, there's 3 or more ribs broken in at least 2 or more places in those ribs, which will cause this chest wall to move in a paradoxic fashion. When the patient breathes in, the chest will expand, except for that place, that piece of the rib that's broken will go in. So you'll have the ribs moving up and down against each other, causing serious pain. Okay, flail chests often causes a decrease in carbon oxygen, and there would be an increase in carbon dioxide. So there'll be a problem with air exchange in the lungs. Restrict the movement of the patient if he's having difficulty breathing. You might want to put the patient in a semi-seated position. It's not easy to breathe with damaged ribs while you're sitting slightly elevated than it is if you're lying on your back. Okay? You could actually use a non-rebreather mask or bag valve mask to supply supplemental oxygen if the patient is on their back. Okay, always remember ABCs: airway, breathing, circulation. If the chest injury is an open wound, make sure you close it properly. And if it is open and it's sucking, make sure that you keep an eye, look for signs and symptoms of dyspnea, difficulty breathing, especially if you think or experiencing something like a hemothorax or pneumothorax. Talking about which penetrating chest wounds, air and blood could escape into the pleural cavity, the chest cavity, okay, causing air and blood to build up, may cause the lung to collapse. Collapsed lung, called the tension pneumothorax. Okay, we need to watch for blood loss, seal the chest wound as quickly as we can with occlusive dressing, administer oxygen if available. If a knife or other object is impaled in the chest, do not remove it and keep it in place. Arrange rapid transport to hospital.